are delivering services, and then from 6 to 7 o'clock, that meeting is for members. So the questions that we'll field, if all the providers ask all their questions, then we can start on members' questions as well. And some of them, of course, you know, are going to be a mixture. So I'm Senator Liz Mathis.
I'm State Representative Molly Donahue.
And our legislative session starts on January 13th. So, yeah, right, yeah. 10 o'clock.
How many days do you have for regular session? 80 days?
100 this year.
100, usually 110.
One year 100, 1 year 110.
So we wanted to get your feedback. We want to find out all the information we can from providers who are doing the service, and anything around billing, anything around ideas around the children's system, that sort of thing. And let us know where your needs are and where your ideas. So I want to go through this real quick. And for most of you, this is pretty elementary. And these are some of the, you know, for those who are new at this or just starting out, Medicaid Member Services has a toll-free number, and their website is Iowa Health Link, so you know it's iowahealthlink.gov. When you go to that, I think bills and some of your communication, your correspondence always says Iowa Health Link at the top. These are the two groups, managed care organizations in the state of Iowa. One is called AmeriGroup, and the other one is called Iowa Total Care. You might recall back in 15 when this was being designed, and then the rollout in 16, we started with 4 managed care organizations, went to 3. Now 2 of those have changed, and Iowa Total Care came in. AmeriGroup's been here at the start, and so they started with a smaller group, and now they've grown into a larger group. So they have about 600,000 Medicaid members, so it's about 300,000 and 300,000 for each. And then Medicaid Providers Services, and all of you have this, I'm sure the providers are experienced, and so you have this number to call, but I'm just putting it out there so that you have access to this information. And then AmeriGroup and Iowa Total Care also have provider services. And I want to hear about some of your experiences, some of you providers who have called these numbers. I'd like to just hear what your conversations have been and if you've been able to work toward a resolution. And then the Ombudsman program. So we talk a lot about this. If you are not getting through to member services and hi Scott, and you are or Jeff, sorry, if you are if you're not getting through, or you feel that your case has not been fairly considered, then you can go to the Managed Care Ombudsman program and talk to them and see what your recourse is. You can also contact your legislators. So if you just Google Iowa legislature, you'll see a page that comes up like this, and it's legis.iowa.gov. And on that page, right back here, it says legislators and legislation, and I'll go to the next page. And if you want to find out who your legislator is, it says find your legislator right here on the page, right there. And you can click on that and you put in your zip code, or you put in the city where you live or the county, and it will tell you who your legislator is, and it has a direct email contact for them if they're having issues. And then that's what it looks like if you do go to it on this page. If you know who your legislator is, the emails are all on the side, and there are, even when you click on the name, there are phone numbers and addresses, their home phone sometimes, if they're courageous enough, and their home addresses on there. So that's what I wanted to go through with you. I know that many of you have had conversations with the managed care organizations in a number of different ways, but we're going to talk tonight about how maybe those conversations have gone and how can we remedy situations for you. So,
know, outside of, you know, meeting and talking to people that I know, like Garrett, on the recent, you know, recently over the last year since I'm doing this, there are a lot of people who are not receiving services that they have been told they would have. I know Garrett has had that issue with his group, not getting him the services he needs, and I know that that's something we need to work on. I'm just here to learn because she knows, and as well you know, a lot more than I do as a new legislator. But I'm here to do whatever I can for my constituents and people as well, so.
So since this is a talking post, a listening post, either or, let us know where to begin. Who wants to go first?
Yeah, okay, I'm Garrett Fry, but I'll go first, and I'll just overall go through it for myself, and then if anybody else has a question, concerns, or anything else, please feel free to also go ahead and tell your story. But for me, I've been on Medicaid for approximately 10 to 12 years now, for a lot of my life. My family, I can turn around. My family, we kept private insurance, so private insurance helped out tremendously over the years. They paid for most of my medical supplies, most of my healthcare needs, which that provided me 16 hours up to 18 hours of a nurse per day, which 10 years ago, my father passed away, and it was about the time I began my adventure with Medicaid, and I'm not sure if all of you are familiar, but after someone passes that has a disability, that has like a child or family member, 2 years after they pass away, they're eligible for Medicare also. So for me, right now I have Medicare and Medicaid. Through Medicaid, I have Amerigroup. I've had them, for 6 years or so now. And they have worked well with us. Every 3 months, I believe they come out with a case manager that is assigned to my case. They come out and meet with my family, basically me and my mom, and they ask how things are going. They try to get feedback from us, but they are also limited to their resources and the totality of what they can do. We can't provide all services, but Medicaid is there in place for those that need it. There is a few things that are lacking with both Medicaid and Medicare, but I feel as though I'm an advocate for others like me and anyone that needs services through Medicaid, whether it's waiver programs or, mental health, that they really need those services as well. But my family, a couple months ago, it was anywhere from, receiving, our CDAC money that we're supposed to be receiving. And that was pretty easily resolvable. I had to contact a few of my friends. Molly Donahue is one of them. And then I contacted a few of our other state legislators, got in contact with my caseworker, and then got in contact with a couple of other people at a group. But within, I'd say 2-3 weeks, it was all resolved, or less. It was about 2 weeks, I'd say. But it wasn't too long. It was just the frustration of it all. There's lots of frustrations that we have.
So Garrett, that was around your CDAC provider, trying to
Yes.
get that resolved?
Yes. See, that provider is my mother, and she is my primary caretaker also. So that it put a strain on us, like financially, and people in my situation, we just don't need to have those types of things come up. And then there's other little things that come up periodically, but there needs to be more talked about within the Medicaid system itself, how to fix certain loopholes like the paperwork and different things, charting, and different ways to improve our healthcare system instead of making it more difficult and more challenging. And I think simplifying could be simple solutions, such as, in my case, obviously, I'm 37 years old, and I was paralyzed when I was 4 years old due to a motorcycle accident, but my condition hasn't changed, will not change, and I feel as though my primary doctor and was working with a caseworker. I feel as though in my state, everything, my supplies, my services, cares, all are documented. I don't understand why I shouldn't be being provided what I needed. So, that's
Gary,
just,
what are some of the things you're not being provided that you were supposed to be getting?
okay, there
So
we
that other people
go.
know.
There we go, I'm sorry.
Yeah.
I can take over, but thank you, Polly, for asking. The things are not being provided, simply are, from our nursing agency. And we only receive, like in my case, we only receive like 2 hours a week of a nurse. But I am eligible for 5 hours of others per week. 1 hour only 20, 30 minutes of services. And then they gotta go somewhere else. And then the same thing for an aide, which right now I do have an aide that she's good, she's still learning, but, because I can train my own staff. I can train the nurses myself. My mother's always there, so I'm lucky to have that support and that, you know, that's a great thing to have. But there's other services, you know, I feel like, you know, when the aide comes for an hour, the aide for an hour basically only has time to get me up and to wash my hair, and that's pretty much it during the day. And then my mom does the rest, which that's 23 hours, pretty much 23 to 24 hours every day. She has to do everything. Or, you know, my brother or friends help out. And then the last thing I'll say is with having both Medicare and Medicaid, I'm not providing all of the services or the supplies that I need. One such thing is I'm on a ventilator, so I have a trach tube. Well, my trach tubes are only being provided for one every 3 months, so that's basically 4 per year. But that's my lifeline, and I feel as though I should be able to receive what I need and what I feel as though would be adequate, medically needed, medically
What did you used to get, Garrett? Sorry.
What?
How many did you used to get?
I used to get 2 per month, no matter what.
And now you have 4 a year.
And now I have 4 a year. So if that tells you anything, and the same goes for other things. There's suction catheters, which I have to suction, basically clears out secretions out of my bronchial tubes, out of my trach. And suction catheters, they cost $30 per kit. Per kit. And you get 50 per box or per whatever. And I just feel that's outrageous for one. But two, if you buy them online, or if you buy them out of pocket, they cost between $1,000 and $3,000. To me, there's something wrong with that. But again, that's my lifeline. I have to pay a certain amount out of pocket every month, but
Here, can we take a time out here for just a second?
yeah, go ahead.
And so hold that thought. So I want to make sure that some of the providers in the room are able to talk to and maybe reflect on what we just talked
Right,
about. Is
right.
that okay?
Yeah.
If we do that?
Yeah.
I know that, you know,
We only
it's
have a
difficult for
certain
you to
amount
get
of time.
here, and I want you to have time to
No,
talk about it.
That's
So-
fine.
So, and so we,
But yeah,
schedule
no.
the providers. Is that okay?
Yeah, yes,
Okay.
thank you.
All right. So providers in the room, what do you think? And
Well, I'd like to piggyback off of a couple of things that he said about, you know, just the service provision, the service provider availability. You know, one of the challenges that we face, it's a huge challenge, is first of all, to find qualified staff. We can't pay them enough because the Medicaid reimbursement rates are so low that we can't pay them enough to keep them, or even to get them to look at at the jobs that we need them to do, those direct support professionals. When our average wage is around $12 an hour and Quick Start pays $16 for an entry-level position, I mean, those are the kinds of challenges that as a provider that we're faced with. Trying to recruit and retain staff is huge. And I get it, they come in, they get the experience, and they move on. You know, I couldn't live on $12 an hour, but to try and get those reimbursement rates up to a level that's competitive with Quick Start, with Casey's, with Hy-Vee, it's imperative that we have better rates so that we can pay our folks. So that people want to work in this field, they want to do the jobs, but they can't live on $11 or $12 an hour. And so I think that needs to be a huge priority for the legislature to look at this year. You know, to find a way to reimburse our programs enough so we can pay a living wage to folks, so that we can recruit and retain people to come and work in this field.
So all the future ready things that we've gone to and talked about, direct care workforce, reimbursement, low reimbursement seems to be the number one
It's
issue.
huge.
So, do you think that's the only issue? What are some other issues? Do people want to seek or be challenged with higher training? Do you think that they want to do advanced training? You know, what are some of the other things that will retain, keep people in their jobs, along with higher wage?
I think another piece of it for us has been, I've had staff tell me, I didn't come in here to write a book. I came here to take care of people. I want to take care of people, but when most of my time is spent on documenting to prove that we did this service, so that when they come in, when the managed care companies come in and do an audit, we have adequate documentation that says that we've provided medically necessary services. And that really has changed the level playing field too. People say, I spend more time on documentation than I do taking care of people, and I got into this field to take care of people and help them in their recovery journeys.
In what areas do you think we could cut back in documentation? Like what areas?
Where do you want me to start?
Just start.
You know,
And chime in, everybody.
the service plan piece of it, just the daily the visit, the individual visit documentation, where you have to go through a 3-page checklist and narrative. Every time you see somebody. So if you have somebody who's, for example, is in a 24-hour setting, every single shift that person has the same kind of requirements. When we know the individual, maybe they don't need to have that kind of level of documentation. It doesn't need to be so intense to prove that we're taking care of the individuals and that they're getting the services that we said that we would provide them. So I'm sure I see a lot of heads nodding, and it's been a huge conversation all over the state with other providers that I've talked with.
Other providers, tell me some other things around wage, so much documentation, service plans, visits. What are some other things?
Timing of reimbursement, that we're not being reimbursed on time. We will have cases 6 months before we even get paid. Or there'll be loopholes that you can't track down, or one number's been transposed, you can't get a hold of anyone. So that's a problem, and we're not being paid enough to provide the services we need to provide. We're also not being paid in a timely manner. And so that means that access is limited. If we can't keep our doors open, we're not going to take care of these patients. And so even though they have a type of health insurance, the insurance is not adequate for providers to continue to allow their access. And so we're seeing that, so then they have access higher levels of care. We see more ER visits. We see sicker people coming in with it. And so, I mean, the system, as you know, is broken. And I think that we're at the point that I'm glad you're having this, because I think it's time that you hear from providers of what we struggle every day. It's not that we don't want to take care of people, but it's become so unrealistic. And if you don't have the right buzzwords, if you don't have the right sentences, even to say, I saw somebody face to face, if I don't have that in there, then I'm automatically rejected. And of course I saw him face to face, it's in my note. I mean, and some of it's just a given, but it's those little things that just wear us down day after day.
So let's talk about claims for a minute. So you file a claim and you feel that your billing department has done the right thing and they dotted all the i's and crossed all the t's, and you run into something like that. then is there a lack of consistency on the MCO's end? Is there, tell me about fair hearings, tell me about, if, we tried to pass a bill last year and the year before that on an independent third party looking at no resolution, you know. So maybe it's a resolution for the MCOs, but you don't feel it's a resolution for you as a provider. We tried to bring that up. So tell me more about the claims part of it and when they're kicked back. Is it a quarter time your error and 3/4 time their? Do you find errors on your end as much as you feel that they're creating errors?
We had, I don't know if I can, we had just, you know, again, it takes a while to get set up each time there's a new player in. So just that process of getting it all set up again, and then we were paid actually for some July and August, and then in September and October it said, you're not a provider.
Yeah.
So we had to, then we didn't get anything, so it was all zero.
And what happened? What was the glitch that caused that to
Well, then we
kick you
had-
back up?
We had to go and stop, and, I mean, again, it's trying to get a hold of somebody, so then, I'm not even sure, but we had to go through the process again, and then we had to look at it again, what we are approved, obviously, we had been paid and provided the services, and so I don't know, really, you know, just, there's kind of always those random things that.
Did they say it was on their end?
I don't know if they've been owned up to that.
Because I'm thinking, what if it happens again?
Yeah.
You know,
It's happening now.
Acknowledge.
It's happening right now.
Okay.
So I track very carefully how I'm a mental health provider,
And your name?
Patty Kilbach.
Okay.
And we've been tracking, we got paid we didn't get paid at all from when they took over, when Iowa Total Care took over.
So now.
Until about September, we didn't get
So
paid
for 2 months.
for a couple months. And then we got paid for about 6 weeks, and then they stopped paying us again. And so now we're like trying to figure out, we keep getting these rejections. We've gone through, in the last 2 weeks, we've had 200 rejections on claims saying that we're not an authorized provider.
That's the same thing that we
And
experienced.
we're like, are you kidding me?
Like how many claims versus, like, are you submitting like 1,000 claims or 2,000 claims?
We only see about 240 people a week.
Oh, awful.
So like,
So it's
we're having our
almost
claims
claims
or,
then.
yeah, so Iowa Total Care is a substantial part of who we are billing in America. 62% of our clients are Iowa Medicaid, like MCO consumers.
Right.
And so a large part of our budget is built around MCOs
Yeah.
being able to pay timely. Well, then we're not getting that
That's my
income.
point.
And so it's really stressful, especially right before the holidays. And so we're really concerned because, you know, like we found out Thursday that 105 claims denied towards the end of November, like right before Thanksgiving. And then Friday we found out another 65 claims denied. And then we found out this morning that more are denying. They're not fixing the problem. And they're not being transparent about it either. We just keep getting the runaround about like, well, I'm not sure why that's happening. I'm not sure why that's happening. So,
And are we still having to submit those claims appeals paper-wise?
Iowa Total Care doesn't have an electronic system to submit reconsiderations.
Yeah, so.
When they signed up, that was something that they said was coming, and the last, I went to a meeting with them, and they said that's not on the horizon, but that's such a huge administrative burden to send paper copies to their office in Minnesota, maybe, I'm not really sure, but it's really hard to track those as well.
So let me get this right. So you filed a claim initially digitally,
yeah.
and then they kick it back.
Yep.
And so for reconsideration, you have to file paper
Yep.
after that.
Yes.
And what reasoning do they give you because
None.
they just don't
They're
have the
not-
system?
they don't
set up
explain
for
it.
that?
There's no
system for it. They're not set up.
They're not set up.
And then that just adds a huge length of time to it.
That's part of it.
Okay.
In the world of PT, I retired, but before I left in October, in the world of PT with AmeriGroup, you had to submit an authorization request for everything past your evaluation. And what they would do is take 2 to 3 weeks to get back to you before you could see the patient and when you were gonna get paid.
If they got back to you.
And that's it.
They
It's
weren't getting back to
employed
us.
so that the patients don't come back. They get so frustrated with it, they don't ever come. It's one of their employees is to slow down the system. It's an active employee, and they're also every few months changing the rules.
Yes, which in mental health services doesn't make a lot of sense, because if you can't authorize a higher level of outpatient service, community support program, and transitional living program, and they've got to do it, I've got somebody discharging from the hospital, I don't have anybody that can take care of them in a timely fashion, so they end up back in the hospital, in the ED, and then back up on the unit. So it eventually it costs them more money on the back end if they would just pay the service on the front end.
This is a disaster.
In addition to that, both of the MCOs, but AmeriGroup is really good about, they will send you a notice of an authorization, but they send it usually about 3 weeks to a month later, and then you get 15 copies of the same authorization.
Yeah.
It's a total waste of postage and paper.
So they send it to you, paper.
Paper in the mail, but then they send us like 15 copies of each authorization. So, which doesn't make any sense to me why they would mail it in the first place when they could just fax it and then send it to us so many copies per authorization.
So AmeriGroup, is that, are they doing the same thing that Iowa Total Care is when you do it digitally, reconsideration, can you do it digitally?
With
With
AmeriGroup, yeah.
AmeriGroup? Okay, so, and then you say that Iowa Total Care says they're not gonna get to that anytime soon.
Well, in their meeting a couple weeks
They
ago.
have no time frame on when that would be a possibility.
Okay. And what level of person were you talking to?
Brian Sanders?
Okay.
Is that big enough for you?
I'm just thinking,
He's the director of long-term care.
yeah.
He's pretty high.
More.
So one thing that I think was disappointing about having these issues with Iowa Total Care is that initially in the conversations that we were having, I was able to negotiate with them a higher rate, which was a really big deal because we had been sitting at the floor for a very long time. So to hear, okay, well, we're gonna actually fund the meals was a really big deal. So to then find out that all of our claims are being rejected, or when they had that glitch where instead of getting 2 meals authorized a day, their system thought it was only 2 meals a month, so we were serving meals all month for, I don't know, 200 people, and they kick it back and said, no, they only get 2 a month, not 2 a day, and so we had to resubmit that again.
2 a month?
Right, it was, and I think that was some kind of computer glitch, but, you know, when we were very excited about the idea of actually being able to negotiate this higher rate because we haven't been able to move that much with AmeriGroup yet. So for that to then just get kicked back was disappointing.
So then what did you do? How, do I remember all of
We
them?
had a whole bunch that were kicked back.
Yeah.
9 months or a year ago, they were like 8-year-old claims. I don't
No,
know what they
those
did.
were like 2-year-old claims that okay, so they came back after 2 or 2.5 years and said, oh, that wasn't right from 2.5 years ago, so we're gonna need all that money back that we paid you for those meals. And it was,
And who was
how
that?
much was that?
Which
Was that
MCO was
$6,000?
that?
We just had one that took out over 1,000.
Yeah.
Before you came back, there was one that was over $10,000.
Yeah, it was a lot.
Like $15,000, $20,000.
So,
After like 2.5
which
years.
MCO was that?
I think it was American.
I think it was American.
AmeriGroup.
And did you pay them?
UBH just did that.
If we didn't, I'm pretty sure there's
No, we
like
paid.
2 claims, so yeah, we did.
So you had to pay $10,000?
I can't tell you the exact amount, but we can, it was a
It's a large-
significant amount, yeah. And well, first we had to pay somebody to go back through all those claims, you know, and try to get as many as we could straightened out. I can't remember what exactly the problem was, but I can tell you it was a lot of money, it was a big pain. I know those two things, and we provided the services and didn't get reimbursed. And, you know, I'm thinking.
And we didn't
it was-
know it until 2.5
Yeah,
years later.
right. There was something about the notice of decision or something, I think, in the beginning. I don't remember
Something
what it was, but.
something was messed up.
Yeah.
Okay. Yeah.
Years
And,
later.
I mean, that, I'm
And
certainly
we
not
only have-
diminishing this in any way, but even in the past, those who did Magellan and Medicaid fee-for-service, that would happen as well. They would come back to you 3 years later and say, you owe us $100,000 or something like that. It was, you know, because they had overbilled or they had over-reimbursed or for whatever, there was a glitch. So that's not unusual, but in this case, it's happening so often It's just happening more often. Has anybody else had that happen where they ask for money back? And was it a big amount or a smaller amount?
We've had it happen a couple times, I think, but it averages between like $900 to $2,000 each time.
You know,
You only have a certain time to resubmit to them.
Yes.
And I don't know what that time is, but it's
90
not 2.5
days,
years, I'll
yeah.
tell you that.
It's 90 days and the clock starts again or something.
180.
Yeah. So, so how many of you are willing to disclose how much the MCOs owe you right now in provider services? Ballpark range.
For my company, and we're pretty small, they owe us about $70,000.
All right. Anybody else want to disclose? Does anybody else have?
I don't know.
Is anyone else owed?
I know there's
Money.
another company in town, I won't name it, but had a meeting last week, shared that Iowa Total Care only owes them $500,000 a month.
Yeah. The hospitals at one time, UIHC was owed $25 million.
That's a huge amount.
Yeah, that was at the beginning. That was in the first year, about $25 million. I worked for Four Oaks, we wrote $2 million. But they did pay. How many of you have attorneys that you've used? And when you write a letter, do they respond?
Our health did, we have not had a response from United Health yet.
And so you said you hadn't received a response from United Health
We
yet?
don't have any resolution yet for our
Okay.
claims that are outstanding.
IME is withholding money for some of those claims until they have to reach a certain level of getting all their claims paid off before they're going to receive their final payment from IME for what they're doing. So I would encourage you to let IME know that you're still owed a significant amount of money to do that. Write them a letter too, if you haven't already, CC, I'm sure you probably have. Is anybody else owed by United Healthcare still? Has everybody been paid up by United Healthcare?
We have some balances too.
Have some balance? Okay. Is it a significant amount?
It is to us, you know.
Seriously?
Therein lies
Yes, and you know, the hospitals, you know, the whole theory around the ACA was to make sure people were, you know, had insurance and they would be able to pay for their care and not always go into the ER. And it was actually working that way. There were fewer charity cases, at least in our local hospitals, fewer charity cases and more billing around that. Whether it was private insurance or it was Medicaid and Medicare, there were payments being made. And then we had some issues around the new administration saying it wasn't mandatory anymore to have health insurance. So a lot of people just didn't get health insurance and they've been ending up with ER again and the costs are driving up, so the charity cases are starting up again. So the hospitals, and you see this in small hospitals where they may have been able to write off certain debt, but because the margins are so slow, like you're so tight, like you're saying, reimbursements for our healthcare workforce, their reimbursements for service obviously are just as tight. And so we've seen a lot of dire straits among some of the smaller rural hospitals. And so that's become a problem. And some of our smaller rural skilled nursing facilities that were maybe 20, 30 bed units in a small town, and it was a place where the community realized and recognized them as the skilled nursing facility in that area. Now some of those places are being closed because they just can't get more insurance for that. So we're well aware of that as legislators. More provider information. Your concerns about this and where this is headed. And have you had any light bulb moments where you think, if only we did it a different way, if only we did it this way, like you're talking about the paperwork, right? And then you could, in certain areas, you could trim back on that paperwork, or digital, a digital return on that. So what are some other areas where you could see some solutions in this?
We're now looking at teletherapy as an option, and I believe that Medicaid is going to reimburse for it, which is great, because it's going to reduce barriers to access. But we have a concern of, what does this look like in the future? And just a comment that I wanted to make is that I felt like for the few months that IME only was dealing with us, everything was going smoother. So it just seems like, I know that was a very short time, but I've been in practice for 15 years, Magellan, and then, the MCO switch and all of that. But for those few months that IME was the only entity that we had to deal with, like they knew what they were doing, and it was smooth, and things were efficient. And so it seems like the MCOs just mucked everything up and keep mucking it up because they can't stay in the business, and they're not, they're sticking around. And then also one last comment that I really feel compelled to share is that for 15 years, we've not had an increase in reimbursement in the mental health field. And we're not eligible for the EHR incentives, even though that is the route that most of us are going. We're not a provider that is eligible for the EHR incentives for the Medicaid and Medicare. So that's really unfortunate for us because we're paying for that, but we're disqualified from receiving the benefit of going that direction.
I thought we approved a healthcare workforce increase in 2012. Do you remember that?
We didn't get it.
All providers got it. There was an increase, and so
Say that again.
that in 2012, there was a healthcare worker increase, wage increase in 2012.
I don't think it went
I
there.
got thank you notes. I mean,
Yeah.
it was a line in the HHS budget, I believe. And I got thank you notes from
I
some
don't think it
providers
went to every provider.
Okay, so maybe mental health, just mental health, not physical health.
We've been billing the same, we've been getting the same reimbursement rate since we've been in practice.
And that's been 15 years. Okay.
And also, Senator Matthews, a lot of the things that are being done, like the actings for people that have mental health services in their homes, they're being, because the rates are so low that they get reimbursed from the MCOs, those are being supplemented by the regions. I don't know if most people even know that, but that's ridiculous, right? We should have the insurance rate be high enough to keep the providers in business.
And it was also a 5-day-a-week program, so mental health didn't occur on the weekends.
Yeah, people weren't
We only,
schizophrenic on Saturday or
like,
Sunday.
one of the comments that was made was, yeah, exactly that. And so the ag teams could get paid Monday through Friday, but if there was something that occurred on the weekends, they couldn't get reimbursed for that time. So I know our region's supplementing that.
What was the reasoning for that?
Oh, come on.
Well, I'm just
Control
saying,
costs.
I mean, was it something that was created in rules?
I think when the program, my understanding was when the program was developed, nothing had changed since the program in terms of rates or reimbursement or anything. And I know that's something that they've been working, trying to get changed. I know Kathy Johnson's been instrumental in that.
Yeah.
I've got a question for the group. We're talking about reimbursement rates. What percentage are we off of where we need to be for different care providers? Can we get an estimate on that? Because if I go to Des Moines and I want to argue for something, I want to know whether it's 20%, 30%, 80%.
Or 15.
Yeah, I'm just curious what your feelings are on that.
I would say we need to figure out exactly how much money it would take to give everybody the appropriate raise they would need to stay in their profession first before. I'm sure there are a lot of factors involved in answering that question, but I think that's one of the more important ones.
Well, like our organization knows what it costs us to do business, and we know what our reimbursement rates are. So I mean, I'm sure other organizations would have access to that information to be able to.
Just a guess.
Medicaid pays for us in a 45-minute session, Medicaid pays 46% less than private insurance does.
Yeah, even just bringing this
when
damn
they
thing
pay.
private insurance.
When they pay. If they pay, I'm sorry.
Is there ever gonna be consideration for the FQHC's 50% fee reimbursement and not pay for service?
FQHCs, so federally, that wouldn't be in my area because they're federally funded by Joni Ernst and Chuck Grassley and Representative Finkenauer and Cindy Axne and Dave Loebsack. They would be the people to ask. But in terms of the work that the Eastern Iowa Healthcare Center does here locally, so around maternal health, around mental health, there are Medicaid dollars that roll through, state Medicaid dollars that roll through, as, you know, the match, the FMAP match. And so we haven't talked about, we've talked a lot about reimbursement dollars for everybody, you know, not specifically some health clinics. What we've done in the children's system, we have the Children's System Board, we have different subcommittees. So one is on teacher training, another one is on what will screening, mental health screening look like, another one is on the healthcare workforce. And so what we did, you know, we listed out all the jobs that have any kind of interaction with healthcare, the mental health workforce, the children's mental health workforce. And then we did a cross comparison with states like Oregon and Washington State, who have very robust systems, along with Minnesota and Illinois and Wisconsin, so more Midwest, to just see how much people in all of those categories are making, whether it's yearly salary, or it's per hour, or it's contract services, because a lot of work is done contractually. So what would that look like? And right now, we're still trying to do that comparison. But those, you know, it really, I think it really has to do with compare with what other states are doing. Because we lose, not only do we lose teachers to other states, but we're losing healthcare workers to other states, especially if you live in the Quad Cities and people can go to Illinois and get, you know, a higher wage, or if you know, Albert Lee, Minnesota, you know, and you live in Mason City, right across the, you know, the state line. Yeah, Dubuque, exactly, the key city. And so I think we need to be more cognizant of that. The other thing about telemedicine, and some of the doctors that started doing that said that they, in some ways, you know, they weren't getting the same reimbursement that they were getting when you actually meet person to person in an exam room. And so the reimbursement was lower when you did it through telemedicine. And I said, is that with private insurance, or is it with, you know, are you talking about Medicaid? And they said, well, both. You know, and you have to think, okay, there's cost in the setup of that system.
And they have to have that system in order to be able to telemedicine.
Yeah.
It's not like they can close their office and just do it from their living room.
Yeah, they do, and the cost is then, you know, entered into each and every unit of how they're going to bill. So they're stretching out that cost of what that's going to be, the electronics, the digital function of it, the Wi-Fi, or the broadband that you're going to use. So there's a cost around that, just like there's a cost around an exam room or a hospital room or anything. So the other part was, this was a psychiatrist, I said, would you ever consider seeing someone on their first visit? And he said, no, I would definitely have a personal visit the first time, and then subsequently on follow-up, I would have a telemedicine visit. That was what he felt comfortable with in his practice. And I think a lot of primary care physicians are believing that too, where the first visit would be one-on-one, and then the follow-up visits would be telemedicine. And then does the insurance company look at that? Well, that's a follow-up, so we're going to pay a lower rate than an initial meeting. So, but it's very needed in our rural area. We
in talking with a lot of providers out of the rural area, we're having a hard time recruiting doctors out there, hard time, recruiting nurses. Something's gotta give. So this is all swirling.
I'd just like to make a comment to piggyback on that. If you look at how reimbursement is, it really has to be the face-to-face. So my office and my staff can do a lot for patients. Patients call in for med refills, they call in for questions. I'm on call after the clinic closes until all night long with people calling with questions or needs. We're not reimbursed for any of that, and we're the only, and I hate to equate medicine with a business, but the bottom line is we still have to function like a corporation because we're paying payroll and we're keeping the lights on it, and we're providing a service, but our reimbursement for our service is so different than any other organization. And so I would like to see something come forward about how do we get reimbursed other than just my time face-to-face? How about all the other services that my clinic is providing? And I don't know necessarily the model of that, but I think until we change that, so then what happens is I have to see 30, 35 patients a day to keep my staff paid, when that's not good for me, for physician burnout, and it's certainly not good for my patients, because part of their healing is time with me, that 5 to 10 minutes just isn't working.
Yeah, absolutely. So the Iowa Providers Association, Shelley Chandler's group, how many of you know Shelley? Okay, so how many are in that association here? Okay. And Shelley, I'm sure she's sent you over the years, the argument for higher reimbursement. And I think that is the number one issue this year from the Providers Association, is talking to the governor about how that matches up with Future Ready Iowa. It's not just about advanced manufacturing and big corporations, but it's also about healthcare providers and what they contribute to Iowa's economy. Think about this, everybody in here has a doctor. I'm assuming everybody has a doctor. And you perhaps have loved ones or children, or you're taking care of an adult child, or taking care of a mother or father, and they have doctors and they have nurses who see them. So imagine the ripple effect of 3 million people in the state of Iowa, where the majority will see a doctor, hopefully, once a year or once every other year, depending on your illness. So what can you say about advanced manufacturing where maybe a job in a certain type of tool or a widget, where does that touch everybody in the Iowa universe, in the state of Iowa? It may not. So we're spending a lot of time looking at that, and we should, because it keeps the economy going and keeps revenues coming in. But at the same time, healthcare workers do too. Healthcare workers keep that economy going. You buy houses, your kids go to college, you're buying groceries, you're doing all of that, and you have to have money to do it. So, would you say, so number one issue, reimbursement?
Yes.
Is that what you're saying? Okay.
I have one question. Okay, my question is, okay, yeah, I'm paralyzed, I'm in a wheelchair, but in my situation, I hate to say this, but I don't like going to my doctor every 6 months or every year, because I'm healthy. I may need to be seen for occasional something, but with my doctor, I have open communication line where if I do get sick, I can make a phone call and talk to the nurse or talk to the doctor, and simply write a message, an email, and they get back to me. And they prescribe me antibiotic if I need it. But my thing is those that choose or would like to choose when or if we could do the doctors, online and talk to them more online, whatnot. But why do we have to be seen, every 6 months to have that prescription refilled and, you know what I mean? Like, to me, it's more of a hassle than a benefit in my situation. Because if I go in a doctor's office, I'm going to be catching something myself rather than, but I don't know. I just, like, for me, I don't even see a doctor on a yearly basis. If I have to, you know what I mean? I'm healthy. But I understand, there's others that have to be seen more. But I think, it should be cut down where, people need to be seen and, go to the doctor, go to the hospital, you don't do it. But if people want less of it, I want to, give that voice to the others. I don't see where, these insurance companies want people to be seen every so often, Well, that's just another visit for me. Because I don't want to get sick. I don't want to go into an office. But, it has to be done. Because it has to be in person. But, yeah, it's just, there has to be ways around it, but I think just to simplify, sometimes, because I think there's overhead costs here from, different providers, and they're not being paid what they should be. But it's those services that it can be a simple email, it can be, like simple one-on-one conversation, meeting with my doctor, it's usually 10, 15 minutes. I don't need any more time than that. But that's me. Every other person has, different questions, different situations. I'm sure a specialist, you can get more time for certain people, but I just want the best because I don't hear what should be provided for every single human being.
And there's something, so here, just to put in from a provider standpoint, I mean, we're also held to different standards that if our patients don't come in, particularly with primary care, and they haven't had their certain screenings, or you haven't documented that you've talked to them about, either checking cholesterol, or have they had a colonoscopy, or have they had a pap smear. If we don't check off all those measures, then we also don't get reimbursed. I mean, this system is so set up for a fee for service, and I agree. I mean, what patients want and what providers want, I mean, we're really on the same page. However, we are being governed by a higher entity that isn't allowing us to provide the care we want to, or allowing you to get the care that you want. And so sometimes it's almost adversarial between the two of us because we don't have time for you, and the system doesn't allow us to have the time that we need to provide the care that we want.
Right, I agree.
Okay, hello everybody. So our first hour, we talked with providers for some of you who have arrived a little bit after. And so I thank you providers for giving us some information. It's good to hear. Are there any final comments, do you think, that we haven't discussed or haven't talked about?
If I may, my mother decided that she was going to take on a new role. She had worked in corporate America for a long time, but she decided she was going to take on a new role and do some in-home care work for people who needed that kind of service. She did this for a couple reasons. One, my maternal grandmother was sent very far away because she had some mental health issues, and none of the providers locally that would take Medicaid would accept her because they said she was a risk. She had spent some time in the psych ward at the university, so she actually passed away in Gowrie, which, if you've heard of it, is very far away, and none of us could be with her when she was put on hospice. So she passed alone. And so my mother decided she was going to take on this new role, and the first client that she took on is a very good friend of mine who was the same age as me, but was diagnosed at 15 with lupus. So she is bedbound. She cannot stand by herself, dress by herself, walk. She goes to dialysis regularly. So this is the client that my mother has taken on, and this is obviously a passion project, right? You know, she loves Camille, and so she would do anything for her, and so she goes over there and takes care of her. She is paid late often. She is paid very little for this. There are times when she's done it for 6 months without being paid because it's Camille. But because of that, she has only taken on private pay clients outside of that. So essentially, there are a lot of people who are missing out on someone who would put her all into the work because she knows she can't afford to stay in business. If everyone was Medicaid, there's no way she could do it. So she only has one Medicaid client.
And we've seen, I mean, right before the MCO transition, I received a letter from a doctor who said that she was going to send out letters to almost 200 of her patients and just tell them she wasn't going to take Medicaid anymore. She had been in another state that had gone through a transition like this, and she was not ready to take that on in a private practice. She just didn't think that she could afford to pay somebody to do the billing and hire extra and do all that was needed to do. I pled with her to keep taking Medicaid patients or keep the Medicaid patients that she had. And she just said, I don't know how to make it. We tried to, she brought an accountant in to say, you know, what would this look like with the reimbursement rate set at such and such, you know, for different things that she was diagnosing or different patients that she had. So that's the fear that I have, is that if the reimbursement rate stays low, if we're still not billing people, we're going to start to see fewer and fewer doctors who will take Medicaid, fewer healthcare providers. As we've been informed, so in Molly, in my district, at least in the Marion area, on her side of the district, we don't have any dentists who take Medicaid. So one of the last dentists was Tom Grimes, and great guy, and he sold his business. He sold his dentistry practice and retired. And he tried to convince the new owner to say, you know, would you take Medicaid? And I don't believe that new owner is. So we've talked to the dent school about it. We've, you know, so there's a whole nother level with dentistry in there. And so, and as they tell us, the mouth is the, you know, the window on the body, you know, so you can even see some things in your mouth that are taking place throughout your body. Dr. True. And so we're very cautious about that and a little nervous about that. And sometimes when you're even looking for a new primary care physician, as my husband was, and this is a personal story, the first thing that was asked was, are you on Medicaid? And he said, is that the first question you're going to ask me? You know, and it was. So, needless to say, he didn't go to the doctor. So, but, any comments, any last comments for the providers in the room?
Okay, Liz, before you wrap up, I'm not a provider, I know you're focused
Yeah,
mainly on Medicaid.
and then we're gonna talk with the members from
But
6 to 7.
I just wanted to, the reason I came tonight, and I've talked to you about this before, is to make sure that EMS doesn't get forgotten.
Yes.
Because they suffer from the same things
Yes.
of low reimbursement and provider burnout. So I know that there's a push for EMS as an essential service, so
Yes.
I just wanted to come to remind you
Thank
tonight.
you. This is Rob Archibald, who is on the Hiawatha City Council, and Rob's been really involved in this, and thank you for coming and listening.
No problem, I appreciate you guys coming to talk.
So,